Dr. Patel, can you walk us through how myelofibrosis is diagnosed?
So for most patients, the first kind of suspicion of myelofibrosis comes from abnormal blood counts. And as I mentioned earlier, that could be high or low blood counts. So for example, some patients may have a high white blood cell count or a platelet count that isn't fully explained. Patients may have anemia, which is a low hemoglobin, and no other good explanation for it. Symptomatically, patients may note abdominal bloating, getting full early, and then a physical exam reveals that they have an enlarged spleen. All of these, in my mind, are clues for a physician to start thinking about could an MPN and specifically myelofibrosis be something that we need to investigate further. The way we definitively diagnose myelofibrosis is with what's called a bone marrow biopsy. So it's a very safe procedure that can be done that helps us look at the architecture of the bone marrow and then also send off a variety of different tests, including chromosome testing, molecular testing, so looking for gene mutations to help definitively diagnose myelofibrosis. I do think it's very important to note that a diagnosis of myelofibrosis cannot be made without a bone marrow biopsy. So even if our clinical suspicion for myelofibrosis is high based on physical exam, blood counts, maybe some additional testing, ultimately it's the biopsy that lets us say with certainty that a patient has myelofibrosis.
Excellent. Thinking about how you said ET and PV can progress, if a physician is expecting, or suspecting that their MPN has progressed, what really diagnostic challenges are, you can you bring forward with that?
Yeah, I mean, so some things that can be hard to tease out. I'd say the biggest tipping off kind of clue for patients with PV and ET that are having their disease start to behave more like myelofibrosis is when their blood counts start to worsen, so going from the high range to the normal range to the low range. And really oftentimes that can be the hemoglobin or the platelet count. Sometimes it can be hard to tease out whether this is because of the medications they're on. So many times we use medications to actually lower blood counts for patients with PV and ET to try and reduce their risk of having clotting complications. So oftentimes when blood counts dip too low, the first thing a physician will do is to reduce the dose or to hold those drugs. We call them cytoreductive drugs that bring down the blood counts. If even after you do that, if the blood counts aren't really recovering in a way that you would expect, I think that further raises your concern for has PV or ET now progressed to myelofibrosis, and that would then prompt getting a bone marrow biopsy done, with the intent being really to look at is there increased scarring in that bone marrow biopsy, and are there some of the other hallmark findings of myelofibrosis, such as abnormal platelets in the bone marrow and things like that. But in my mind, really, it's the low blood counts that can be the first kind of clue that someone's PV or ET is starting to turn into myelofibrosis. Another one could be as if they did not have a large spleen previously, and now on physical exam, you're starting to note that their spleen is large, or they're having abdominal symptoms like bloating, getting full very quickly after just a couple bites of food, things like that.
Great. That's such good information. And when you talk about, the finding out your mutations, can you share with everyone how are those mutations found? Is it in the blood? Is it in the bone marrow biopsy? But how do those test results come about?
Yeah, great question. So in this day and age, we actually do fairly broad mutational testing for patients with MPNs. So the three key mutations, as I'd mentioned earlier, are JAK2, CALR, and MIPL. But about 10% of patients with myelofibrosis don't have a mutation in any of those three key mutations and may have one or more other mutations. Mutational testing can be done from the blood in patients with MPNs, and it typically is fairly aligned with that same mutation testing being done from the bone marrow. Of course, if a patient is having a bone marrow biopsy done, we would prefer that the mutational testing be sent from the bone marrow. But ultimately, if for some reason, say it can't be sent from the bone marrow, or a patient just had a bone marrow biopsy recently and it wasn't sent, sending it from the blood usually gives us a very good sense of what mutations are there. The reason mutations matter is we have developed risk scores to help us get a sense of how likely someone's myelofibrosis is to cause a patient to get very sick, and also for us to figure out what patients may benefit most from a stem cell transplant to try and cure their myelofibrosis. So these risk scores take things like blood counts, they look at chromosome abnormalities, they look at whether patients have symptoms or not, they can look at how much scarring there is in the bone marrow. But then they also look for what are called high molecular risk mutations or HMR mutations. So basically, someone's risk score can get points if they have more of these high risk mutations versus not. We know in general that the more mutations someone with myelofibrosis has, the more likely it is that their disease is going to progress, and the more likely it is that we would be thinking about something like a stem cell transplant if a patient was a candidate for a stem cell transplant.